Thank you, everyone, for joining us once again on Substance Talk. So we'll be continuing mental health and substance use session this week. Last week, thank you, Nhlanhla, once again. And then just presented a real-life cases of individuals who use substances and also going through a mental health issue. Shaun, how are you?
Hi, Dee. Yes, it's a bit chaotic at the moment, as you know. So excuse any shortfalls in the presentation, the actual document. I didn't have time to put the references in, but I'll add that onto the website. But we're busy developing the National Strategic Plan at the moment on TB, HIV care. TB, HIV, and STIs and malaria. So that's taking up a lot of time. And there's some very exciting research happening at the moment as well. That's been taking a lot of time. But I'm glad to be here and alive.
That's great. Lucky for you, this is an open dialogue. So participants, attendees, please feel free to make your comments on the chat and engage with us. So today we'll be engaging in the great debate, the chicken or the egg debate, looking at substance use and mental health. But perhaps we should start at what is mental health? What is psychosis? What do we mean by these terms? And what is it when they co-occur simultaneously? The whole dual diagnosis concept. Shaun, care to share on this?
Yes, so I'm just going to share my screen. When we look at mental health and substance use, we know that there are often correlations between the two. And if we look at what is mental health and what are the issues that we're talking about, and this is a psychiatry survival slide here. And basically, you've got three main divisions of mental health issues. You've got the psychotic conditions, the ones that result in psychosis. That would be things like schizophrenia or some form of bipolar disorder as well, although bipolar also fits into the mood. So that's that overlapping area that we've got. We've got anxiety disorders. And these are essentially controlled by different neurotransmitters in the brain. So psychosis is very closely linked with dopamine and adrenaline, and your mood disorders more with serotonin, and anxiety can be a combination. And in the middle, we've got our cognitive disorders, our dementias, which are an overlap of all of them. And then we've got the domains. We've got sleep disorders, eating disorders, sexual disorders, somatic disorders, which are a bodily manifestation of a mental state, impulse control disorders, and dissociative disorders. So these are the kind of serious psychiatric or mental health issues we're talking about when we start talking about dual diagnosis. And no doubt you would have seen all of this, although you might not have necessarily labeled it as a disorder. You would have seen it in the circumstances that you're working in. So if we look at common mental health issues and the use of drugs or drug dependence and meeting the criteria for a substance use disorder, the general population, and by the way, these are not South African figures. We don't have all the figures in South Africa. These are from the epidemiological catchment area survey in the United States. They're the most reliable figures that we've got. They're not directly transferable to the South African context, but what is useful about them is they were done at a time when things were economically fairly stable in the United States. And so you've sort of managed a little bit for issues such as economic deprivation and that kind of thing. So some of those issues have been mitigated to some degree. But it's useful data anyway, and we certainly see that overall the rates agree with the rates around the world pretty much. So in general population, you've got about 16.7% of people with prevalence of substance use issues. The South African figure we see often is 30%, but that's lifetime prevalence, not point-in-time prevalence. So in other words, 30% of people over the course of their life might develop a substance use issue. In bipolar type 1, and remember bipolar type 1 is the one with the two distinctive symptoms, which is your hypermania and your depressive episodes that are cycling often. You've got 61% use of substances there. You've got bipolar type 2, which is your hypo or your reduced mania, but your major depressive disorders, feelings of depression and anhedonia. Schizophrenia. Schizophrenia is generally a psychotic disorder, but it's actually a clustering of about 108 different symptoms, which can be clustered in various ways. There's some people that say that schizophrenia is nothing more than a name, but certainly there are people that present with these symptoms. Depression, about 27% of people. We'll talk about what drugs they use later on. Anxiety, 23% of people. So in all cases, this is above the general population. The ADHD figures don't come from the ECA study. They come from other studies, and they're quite broad, between 30 and 40% of people. Now, as I mentioned, I don't have the references in here, but I will include the references in the version that goes online. Right. So if we look at personality disorders, and what do I mean by personality disorders? In the old days, you used to call them cluster B. Often personality disorders such as borderline personality disorder, but there are a variety of personality disorders. But we're not talking about the so-called addictive personality, where people say, oh, he's got an addictive personality. There are certain traits in people that can make them more vulnerable to addictions, but there's no such thing as a distinctive phenotype of addictive personality. However, certain personalities are much more likely to use drugs. Your antisocial people will tend to use drugs either as a form of rebellion or just because, and usually are seeking enjoyment out of their drugs and leading quite a hedonistic lifestyle often. Virtually 100% of people I've come across that are antisocial use one drug in some way or another. I often tell people we must remember that most antisocial people will use drugs, but it doesn't mean that all drug users are antisocial. But you will bump into the antisocial people amongst the people who use drugs. And especially if you look at recovery groups, you'll find a lot of people there who are pretty antisocial and quite dictatorial in those groups. Borderline personality, we see quite a lot of people there using drugs, and then your avoidant personality, your paranoid, and then your schizotypal personality down at the bottom here. One of the interesting things to note is that people with serious serious mental health issues tend to use less quantities of drugs, but have more bang from that drug. They suffer more harmful side effects, and certainly react more to the drug than your general population would react to the drug, which might go some way to explaining why they develop the substance use disorder or the dependence at the same time. So, Dee, over to you quickly.
So I just want to catch on something that you mentioned. Are you telling me, because I've heard this so many times, that this person has an addictive personality or an addiction gene attached to their biology?
Yeah, so those are interesting questions, because the genetic one is there seems to be some level of genetic vulnerability, but it is not anywhere near as strong as they used to think it is. And you can never really adjust for confounding factors in something like that, because when we're talking about trauma, we know that trauma is passed down through epigenetic changes in individuals, and also the stresses that somebody who was traumatized early in life and then gives birth to a kid kind of get carried on to the kid as well in some ways. So it's very difficult to say. They haven't isolated an addiction gene at all. In fact, they've said pretty much that if it is any genetic component, it's a number of separate genes. And in terms of the personality disorder, they've done lots of tests around that, and they've seen no real phenotype around that says that here we can positively say that this person has an addictive personality. We see people who are attention seeking, perhaps, or sorry, let me take that off for a second, who are attention seeking, who are sort of on more antisocial, and certainly, as I've said, those personality types would be more predisposed towards addiction, but you don't get the personality disorder of an addictive personality as such. And there's been lots of studies to try and prove that. And as I say, unfortunately for people who use drugs, the people that tend to stand out are the ones who are more loud and more antisocial, or even in some cases psychopathic, although that's not a formal diagnosis we know in today's world, but it is a very real occurrence, and those people tend to stand out more, and frankly often give people who use drugs a bad name. So but once again, we've got to empathize that some people are born the way they are. Doesn't mean they can't change some aspects of them, but personalities are pretty fixed actually. You can accommodate them, but it's difficult to actually change them significantly. I've met people who are antisocial, who work in psychiatry and in forensic psychiatry, and they claim that's the best way they could manage their antisocial personality issues was to do something good with them. Yeah. And although today we see books like Tap Into Your Inner Psychopath, and that I don't know why we would want to do that, but anyway, apparently it makes you get ahead in business, which says more about business people than it does about mental health. Anyway.
Yeah, sure. So another nature versus nature debate. But back to our current topic. So what do we treat first? And we just want to put it to our audience. What would you want to treat first? Do you treat the mental health issue? Do you treat the substance use? Are they equally important? You treat them at the same simultaneously, but with a special focus on the drug, or vice versa. Please, I believe that the poll has been lodged, and please provide your answer on there, and we're gonna have a debate. So this is when we will meet Dr. Sonia Posh. Did I say it right?
Yep.
Yeah,
Pasha.
she's a clinical psychologist with a special interest with self-harm and suicide amongst adolescents. So she will be coming from the mental health perspective, and Shaun, you'll be coming from the substance use perspective. I think that your home was it was an interesting day when you recorded this video. I hope it didn't cause any additional tension.
No, it was. Yeah. So let me start off by presenting the first argument. And this is an argument that I've actually heard, particularly in amongst people who work in treatment centers and recovery-orientated treatment centers. And the kind of response I get often from them is, no, you cannot treat a mental health issue while the person is on drugs. They say you have to get the person off all drugs first because of interactions with the medications, that you can't really hold a counseling session with somebody who's high at the time, that to try and work with the person, they're probably going to lie. They're not going to give you factual information. And so the first thing to do is to address the drug use issue. And that's an argument that I've heard many times before. Obviously, I'm presenting an extreme version of it. And certainly there's some points there that I think we should take note of. But let's go to Sonia Pasha, who also was the convener of the postgraduate course in addiction care at UCT. So I'm just going to share my screen and go to that. Right, let me go share screen. Okay, let's go to the next slide.
The first thing that jumps to mind, of course, is that addiction or substance use is often a form of self-medication. We know that people, for example, who've suffered from trauma are much more likely to turn to alcohol or other drugs to deal with the impact of that trauma and the consequences of the trauma they have suffered. Similarly, people might self-medicate. For example, if they have ADHD, they might be much more likely to use stimulants to try and self-medicate for their ADHD. And of course, we also know that there's a huge comorbidity with substance use and things such as depression, other anxiety disorders, and also personality disorders. So very often the substance use is a symptom of other things that are going on and an attempt to self-medicate. So We also know that substance use, or at least harmful substance use, is often a result of the environment that a person finds themselves in. So things such as poverty, crime, poor socioeconomic circumstances, lots of domestic violence, trauma. In those situations, people are much more likely to use drugs. And again, I guess this could be seen as a form of self-medication, but it's even broader than that. I suppose it's self-medication for the whole community, and a way of just coping with what is going on in that community. So these issues are really complex, and in those situations, we probably want to say, well, it doesn't make sense to take the person out of that environment, try and treat the individual for their addiction issues, and then put them back into the environment with the hope that things have changed. That seems very unrealistic. It's like taking one could say a diseased or sick tree out of a forest, which has maybe been infected with some sort of virus, taking it to a beautiful new environment, nurturing it, giving it everything it needs, feeding it well, and then putting it back into the same diseased environment. This is Zigzag. Say hello, Zigzag. And then expecting that tree to thrive. So in that sense, again, we'd probably want to look at the context rather, and look at things such as job opportunities, communal engagement, recreational opportunities, and we're much more likely to address the harmful substance use through that kind of intervention.
Thank you. Okay, so Sonia, we're talking about basically dual diagnosis and substance use, and what you address first, the circumstances or the mental health.
Mm-hmm.
And we've both given an argument for each side, but probably the more realistic thing is to look at the individual and each case on an individual basis. What would you say we need to prioritize in general when we look at people who've got mental health issues?
Well, I don't think one can take the individual out of their context. So I think it's artificial to separate the individual and the context and the system. So ideally, we really want to approach it from all sides.
Yeah, I would certainly agree with that as well. In your experience, especially with people who have self-harmed and who maybe attempted suicide and that kind of thing, do you see a high level of co-occurring disorders with that?
So certainly with the adult population, yes, we do know that the anxiety, things like depression are much more prevalent amongst people who do self-harm. And again, but it's also part of the system again. Often with adolescents, for example, it's what's happening in the family, and often it's an expression of distress. And there might very well be comorbid sort of diagnoses, especially depression, but not necessarily so. Again, what's going on in the family, what's going on in the system, often people are feeling invalidated and unheard, and not seen.
One thing that confuses me a bit is the literature on dual diagnosis seems to be quite unclear and pretty ambivalent about which approach to take, and the data doesn't seem to be so good. And talk therapies have often been shown to help with people with quite severe psychiatric disorders, independent of medication, and that would you find that people respond well to talk therapy in the environments you've worked in?
Yes, but I think an integrated approach is key. So especially in the sort of the public sector, community setting, really you want to work, if you have the luxury, to work with a multidisciplinary team. So for example, social workers are really, really important. We need much more social workers. And for some people, yes, medications most definitely can help. So I don't think we should exclude that either. And even physical interventions or even physiotherapists. But yeah, I think sometimes just having a space where people can talk through these things, and often it's the very first time they've had a dedicated space where they're truly listened to and taken seriously and given a place to reflect on their experiences and what they might mean to them, can be incredibly beneficial.
So the theme of today's topic is not anything to do with cats, but is actually the chicken or the egg. So which came first, the chicken or the egg, the mental health or the substance use?
Well, I don't think we'll ever be able to answer that one. Yeah.
Maybe society came first, the traumas people face, the difficulties they face, And maybe that's one of the things that came first. So maybe it has nothing to do with the chicken or the egg.
Maybe.
Yeah. So in the case of dual diagnosis, what came first, the drug or the mental health issue? What do you treat first? In the case of the chicken, the egg, what do you eat first? Thanks for joining us on Substance Talk and for your input. Okay. Any questions or comments there, Dee, at this stage?
You know, she mentioned the concept of self medication quite a few times, but I wanted us to see the results for the poll. Perhaps the audience had more of an answer around the chicken or the egg, committed to one. And it would also be interesting on your chats, just share with us if this has changed your initial viewpoint. So 50%, majority of our audience felt, you know what, address the mental health issue. 14 were reporting that it's equally important. It seems that focus around mental health issues first took place. So any of our audience where you took the mental health issue and made that more of a priority, did that change or vice versa? It would be interesting to just share that with us. But Shaun, she mentioned a few things around self-medication. Can you share with us around that? What is it? How does someone, a lay person, now start thinking, I'm going to treat myself using that coach?
Okay, so it's not necessarily a conscious decision to self-medicate as such, but self-medication was proposed as an idea in the quite early on in the 90s as a reason why people who use who've got mental health issues would use drugs. And we see a very high correlation between, for example, schizophrenia and smoking. Almost all people you'll find with psychotic disorders in hospital will smoke. You'll see a lot of people using cannabis. And interesting about cannabis is that you've got two types of outcomes with that. On the THC side, we see it maybe pushing people towards psychotic disorders, but the CBD side of it is actually protective. So you know, some of the neurotransmitters in that related to the cannabinoid system are protective against psychosis, and they're actually investigating those in clinical trials at the moment. But at the same time, the THC side of it can exploit a vulnerability that an individual might face. Alcohol is a fantastic mood stabilizer, so we see a lot of alcohol use within mental health issues. And probably the clearest one for me, because of some personal biases and my personal mental health issues, is around ADHD. So we see a lot of people with ADHD using stimulants. However, there was some research. Okay, so I'm just going to share my screen again quickly with you. Yeah, so the question is, do people self-medicate? So some of the research says that actually they just use the drug that's most available. And then they shift substances when a drug isn't available. Seem like pretty convincing arguments that it's not a case of self-medication, it's just a case of drug use. However, we need to think about drug set and setting so that each drug doesn't have a predictable chemical cascade that guarantees a particular outcome. So drugs can serve different purposes to different people in different ways. If we think about typecasts and stereotypes, you would describe somebody using methamphetamine in some stigmatizing terms, which indicate that maybe they're overly hyperactive or have attention deficit disorder in the rest of their life, or people who use heroin in a particular way. So those typecasts and stereotypes would tend to suggest that maybe there's a correlation between the drug use and the mental health issue. Then the other thing is the anything but this kind of scenario. And what I mean by that is that when you've got people who are living with mental health issues, they're feeling excluded, they're feeling unhappy, and that anything is better than their current circumstances. And so what you'll see people moving towards whatever substance is available, not so, for example, with ADHD or with a bipolar disorder, not for a particular reason linked to that, but just to change the circumstances of their life. And any drugged state for them represents a better opportunity for short-term survival and for coping with their circumstances, not even at a conscious level, maybe at a subconscious level, than not having the drugs. So that might explain the differences in the drugs, and why people will switch and change. But if we look at specific, my last point about that, why I think there is some truth to the self-medication hypothesis is the data. And people have produced data showing across different mental health issues as to what people would tend to move towards. Now, if we look at something like ADHD, for example, we would recognize that with ADHD, we would diagnose that person and we would give them, or attention deficit hyperactivity disorder, not just ADD anymore, but if we would prescribe for them something like a concerta, perhaps in some cases, but certainly the more common prescriptions would be for things like methylphenidate or Ritalin. They're stimulants. In the United States, you'd use something like Adderall, which is very, very close to a methamphetamine or an amphetamine. And we will often see that people with ADHD will gravitate towards the stimulant drugs. Why is that? Because they're looking for something. They're looking for the ability to focus. And we know, and they're looking for motivation in their life. It's been hypothesized that there's a suboptimal dopamine system in people with ADHD, which is true to some degree. We know that for a fact in some cases, but also what we see is that people in adult life who get ADHD are able to focus very, very much on what they like, and the things they like. So they get distracted when they're doing work that they don't like, or mundane stuff, but they don't get distracted when they're doing something they like. But when they take a stimulant, they're able to concentrate better on all things in general, because dopamine, which is what stimulant drugs tend to elevate. Dopamine narrows focus. It increases your motivation. It's not about liking, it's about motivation. Similarly, when we look at people with bipolar disorder, especially type 1, who revel in the feelings of hypomania, you feel fantastic. Nothing can go wrong. Even when things around you are collapsing, everything's brilliant. And they often desire that state when they're in their depressive states or in their non or hypomanic states. They want to get back to that feeling of mania and invincibility, and that's why they would gravitate towards those kinds of drugs. So we've got to be, I think there's good evidence for these particular types of disorders for people gravitating towards a particular drug of choice. When we look at the more depressive disorders and the anxiety disorders, often with the anxiety disorders, we will see people gravitating towards pharmaceutical drugs or prescribed drugs, your benzodiazepines and that kind of thing. So we've seen that quite a lot. And for people who suffer feelings of lack of attachment, your borderline personality disorders, and that you will often see the use of an opioid there as well. So I think there is evidence to say that self-medication is a thing. I think that one of the key things to do is, when you look at somebody, is to say, what is it that they're getting out of this drug? If you're going to help them, you need to look at what purpose does it serve in the short term, and why did they become so dependent on it? Because people don't generally become dependent on drugs when things are perfect, around them. In the Netherlands, it's interesting to see that young people these days use drugs far more purposefully. They'll use a wider range of drugs. They'll tend to use drugs which aren't as harmful, but which can get them to a particular state of mind at a particular time. And we see internationally at the moment a lot of research being done on psilocybin. Prof. Hugo shared a paper the other day, which shows very good results for psilocybin with alcohol use disorder. But there's also concurrent studies going on looking at psilocybin for the resolution of deep depression, for end-of-life depression and existential crisis. We're seeing drugs such as ketamine used to relieve very deep depression for depressive disorders and suicidality. And we're also seeing those drugs used recreationally or for adult use amongst a large portion of these populations that maybe have undiagnosed mental health issues or have diagnosed mental health issues and don't want to actually take pharmaceutical drugs on a permanent basis. And so they occasionally self-medicate and that. One of the issues of treating the substance use issues first is that often people will end up in 12-step type programs or in rehabs that follow the Minnesota model of treatment, which is the dominant type of treatment in most South African rehabs. It's 12-step facilitation, and in a lot of rehabs around the world. And problem is that the underlying message in those places is there's no chemical solution to a spiritual problem. They define drug use as a spiritual problem, and they say that no chemicals can help you. So Narcotics Anonymous, for example, has recently released a statement on their World Service, which says it's up to each group to decide whether or not people on maintenance therapies, opioid substitution therapies for maintenance, should be allowed to share in the groups. So there's a question mark over it. And then with psychiatric meds, officially, the official statement is we have no opinion on outside matters. But within groups that I've been to, I know that there's a underlying sort of disparaging message towards people who are even on antipsychotics and that. And we know that for some people, there is very little option apart from medication, certainly in the short term and often in the long term as well, lifelong. What's also interesting when we look at these issues is things like the way that the medications are taken up by the body. So, for example, people who smoke cigarettes, if they're on an antipsychotic and they then stop smoking, often they will suffer a large amount of extrapyramidal side effects when they stop the smoking because the drug becomes more bioavailable. So we've got to be aware of the interactions between their drug and the psychiatric drug. And so that brings me on to the next thing is how do we approach these kind of problems from the point of view of do we have a multidisciplinary team? Have they been evaluated by a psychiatrist? But what if you're just a social, and I say just with respect, I don't mean just a social worker. I mean, you aren't able to prescribe perhaps. So you could be a social worker working with a particular individual, and you don't have a full multidisciplinary team at your disposal, or for whatever reasons, their lack of resources in that particular setting. How can you help this individual? And one of the most important things to do is to address the harm reduction side of the drug use. It's debatable about whether you should try and aim, well, certainly if the person doesn't want total abstinence, work with what they want. But often, if we take the self-medication hypothesis in, we will, if we take away the drug, what else are we taking away from that person? Is it their support mechanism? And what are we going to replace it with? And it's important to keep that in mind, to understand that people are often not being difficult. They can't imagine life without that drug. And so the best response, which is going to keep people engaged and minimize the risks and the harms, would be a harm reduction response to try and get them to stop certain drugs, the drugs that are maybe going to interact most with the pharmaceutical drugs. In fact, there's a very interesting table which I'll put online for you to look at, which talks about the interactions. But you can always ask the psychiatrist or the medical doctor, or the clinical side of the multidisciplinary team who are prescribing, what the drug interactions are, and focus on trying to reduce the risk and the current harms. But remember, people with serious substance use, mental health issues, usually use less substances. Okay, so often it goes undetected because they may be using occasionally. But we know, for example, that if you are taking methamphetamine and you're taking cannabis every day for about 2 weeks, you've got about a 70% chance of having a psychotic episode. That's from an Australian study, which I'll also post into the references. Any questions or
yes, Pam has a question.
Sure.
Hi, Pam.
Hi, how are you? Thanks for the informative session. So what I wanted to find out is that, like you were talking about, if a person comes through, then we must we can use obviously the harm reduction. So, but what I've seen in practice is that by the time the person comes in psychotic, and then the family is also feeling like, because when the person exhibits that psychotic behavior, it's disruptive in the family and in that family setup. So then we will refer now to the hospital, and then the people get peace because at least he's gone for 3 days, and
Yep.
then the person comes back, and then when he comes back, and then it starts all over again. So we're finding ourselves in that thing where, you know, there's like no real, it's difficult in the communities to get mental health, you know, services. And then the person is in and out, the rehabs can't take him, we can't assist with the psychotic, they, you know, so I don't know.
Yeah, so there, in those kind of cases, it is very difficult, it's very challenging. And what will often happen is you'll put somebody in for observation for 72 hours, there's a lot of bed pressure, and what happens is they say, yes, this person is probably, this is probably not just a substance-induced psychosis, and then they give the person medication, and often the people won't take the medication because it makes them feel lousy or less than, and then they will keep taking the substances, and each time the psychosis manifests itself, it seems to become easier the next time, you know, to slip into that semi-psychotic, well, that psychotic state, or with those psychotic symptoms. And so, particularly with the stimulant drugs, you want to try and get the people to use a lower dose. And talking to families, it's very important for families to realize this is a process, this is a path. We've seen some very good outcomes on people who've managed to stick to their psych meds and reduce their drug use simultaneously. Obviously, it is exceptionally difficult when somebody requires less drugs to become psychotic than the people around them, and they, you know, a group of people who are using. And again, it's heavily contextual, so it's very difficult for me to say this is what you would do in those circumstances. I find that group support and group work has helped people a lot. So one of the reasons why we formulated the contemplation group was because the fact that we had so many people with mental health issues, and we felt helpless because we went through exactly the same processes that you did. We had people that were in and out of hospital, that we knew there were no good outcomes, but we found that the people that did well, we were able to engage positively with the family, and there wasn't that kind of total animosity towards them. There was some level of acceptance, and so also the other thing is to take advantage of the times when the person is not floridly psychotic, and talk about the events that precede that. And when people start seeing the link between maybe their substance use, which is exposing their vulnerabilities, and when they start seeing that you don't need to take 100 rands worth of meth every time to feel a little bit better about yourself, you only need to take 20 rand or 50 rands worth, you start seeing gradual changes. But change needs support often, and people need small victories in order to get bigger victories. They're cumulative often. And so what we found is give people small steps that they can deal with. And look, there are going to be external elements as well, such as families coming down on you and that, but you cannot take responsibility for that. What you can take responsibility for is guiding that person and giving them the support structures, especially the smaller steps towards reducing their drug use and reducing the number of psychotic symptoms. Context is everything. And when a person is between psychotic episodes, they do have some level of insight into the issue, and they can, perhaps before the episode begins, they can start seeing the warning signs. So for example, one of the things we do is there was one guy who came in, I remember the story, he kept saying, my mother says whenever I wear my cap, she knows that I'm about to go off the rails, and I'm smoking a lot more tuck. And so I said, well, how do you feel about that? No, she's being ridiculous in that. So then I said to him, so when do you wear your cap? No, only when I'm psychotic and when I'm smoking a lot of stuff. You know, so we had a laugh about that, but then we were able to see that there was a reason behind it. I won't go into that now, but there was a reason behind it, and it was the way he felt in a particular way. So when he found himself reaching for his cap, he would then check in with his counselor and say, I don't know why, but I'm reaching for my cat. And we knew what that was. And then, but we didn't have that discussion when he was Florida psychotic. We had that when he was between his episodes of psychosis. And similarly with the one patient that I've got in a case study that we'll do in the coming weeks, she as well, we were able to identify what led her towards that and why her psychosis was a nice space for her to be in at times. Often because people are sleeping in bad circumstances, and at least when they get admitted to the hospital for 72 hours, they get a decent meal, they're not exposed to the drug stimuli, and they are able to get some peace and quiet. So we found this increase in psychosis amongst people who weren't getting that level of support outside, which is really interesting for me. So this is a complex thing now.
Yeah, I think even Dr. Barrow in the chat just stated that it's about conscientizing a client to their substance use and the harms that and working from the harms and reducing them. Matati, Mr. Mabusela has a question here that psychedelics, what role do they play in substance use and mental health? Because there's a lot of therapy with psychedelics involved in them nowadays. There's a lot of around it. Any comments on that?
So that's really interesting, because there's a very famous case of two little towns in California, and the one there was a bunch of sort of shaman type gurus who brought this particular drug there. Everybody used it, and it was the most enlightening experience of their life. And some guy took it across to the next village or next town, and people used it there, and they were all admitted to hospital for psychosis, and they thought it was a disease and it's a poison drug and all the rest, same drug. And to today, we still see that as well. So psychedelics were also used at one stage in psychiatry to try and mimic the effects of schizophrenia, so people could understand what it felt like. And again, the whole term drug set and setting comes from the psychedelic research field, and Albert Hoffman and Ken Kesey and those guys in the 60s. So it's very important to realize that a psychedelic taken as a therapeutic drug is a very different animal to a psychedelic taken in an adult use recreational type of setting. The setting and the purpose behind the use of a psychedelic has an immense effect on the chemical or the way that you behave on it, or the way you perceive the experience to be. So psychedelics have been used a lot to resolve alcohol use disorders for some people, drug use disorders, opioid use disorders for a particular subpopulation. It doesn't work for everybody, it works for some people. And the reason that it works for some people is because it helps resolve the existential crisis. But apart from that, most psychedelics cause an upswing in neuroplasticity. And so they enable new pathways to be made, and effectively for you to learn new ways of coping in a much better and easier way. So it's a very interesting field. I mean, we could dedicate a whole couple of sessions into the psychedelic field, and there's lots of interesting research. My anger at the system is that we should have been researching this for the last 50 years, but we've missed about 40 years of research, and I'm looking forward to some of the research. I don't want to be presumptive about any of it. I think we'll see some good and we'll see some bad. There is a psychoactive substance bubble at the moment. I think that we've got to be cautious of that. It's not a cure-all for everything, and there's good and harm in anything.
And the need for it to be under that setting plays a huge role also. Purposeful using it under therapeutic setting. Just one last comment. I see we just over time. Question by Coleman, our technical associate in ESRED, asked that, and he's noticed that a lot of his clients that were prescribed Ritalin for treating their ADHD now present. So can the treatment cause a substance use disorder?
So very interesting. I've been looking into this lately, and what the data says is that if you are, as a child, put onto it, taken off it, put onto it, taken off it, that can increase your risk of future substance use disorder. But if you put on it alongside behavioral interventions, it reduces your risk of substance use disorder. And one of so there was an interesting podcast the other day by the Huberman Labs, Andrew Huberman, who's a neuroscientist, and what he was saying was the good thing about it is if you're prescribing earlier for children, what it does enable, it enables them to get the feeling and to generate or to have synaptic pruning that suits their particular disorder. So the learning aligns with that, and then you can so you start earlier, you end the drug earlier, and they don't usually have to take it in adulthood. But that's emerging data. But it's a good question because the ADHD actually is probably the driver of that issue. I saw another question here from Pam. Had we spoken to any psychiatric professionals? Yes, I have, and I've done quite a lot of work with people in psychiatry. In fact, not to blow my own trumpet, but I won an award from SACOP for exactly that, for educating psychiatrists on addiction and harm reduction in 2016. Some people have been very open to it. I remember one person saying, well, you're just telling us what we already know. But it's a pity they weren't applying it in that particular setting. But most people are very, very open about this, and because they're desperate. So I know we're over time, so let me not waste any more time.
Thank you so much and for the engagement. It's very reassuring to continue with this platform. Thank you, Shaun. And please visit the website, Substance Talk, but also you can visit it to share your comments, suggestion on what else we need to discuss that you love. And this has been a great session, Shaun.
Thank you, Dee.
Everyone, enjoy the rest of your day. See you in 2 weeks' time, next other Wednesday. Thank you.
Thanks.